let's kind of focus on the science. Let's focus on the science here, and I will just get started. So my plan today is I'm going to talk about this review article. I feel like the more I read it, the more I found wrong with it. But I also am going to highlight one of the articles brought to attention within this article. And my main point of presenting this today is really to stimulate discussion on this topic of COVID vaccine related myocarditis or myocardial injury, and to try to suss out some of these terminologies and to get our brains working together on this. So, as you can see in italics, I have although fatal COVID-19 induced myocarditis is a rare entity, this topic is in severe need of quality research and attention, and we really need to prevent the spread of misinformation. This is the article I'm using. I kind of touched on this already, but why did I choose this article? Unfortunately, I didn't pick it because I thought it was scientifically sound, but rather I realized that many of the methods and conclusions were not data driven. I find that this article is more opinion driven and has a skewed background information with poor methods, not elaborated on, not clarified, and not supported by data. As a member of the SCVP, I thought it was important that we discuss this topic. Maybe we can provide some guidance. And I was also made aware recently today that this may actually have been withdrawn, but I haven't had time to look into that. So this is a brief slide on the authors in this study. Now, I'm not going to go into detail, but you could definitely do a Google search and you can find that these authors unfortunately do have undisclosed conflicts of interest, they're easily searchable online. And I will mention that no cardiopathologists were reported involved with this so-called study. Okay, so let's talk about some context. While SARS-CoV-2 vaccination has been linked to myocarditis, we know this already, it's not usually fatal. Okay, this is usually a rare complication. There are various vaccine reactions, however. One can have the following reaction, but myocarditis is merely one of those reactions. Please think about the concept of myocardial injury and realize that this is just an umbrella term and not synonymous with myocarditis. Rather, myocarditis can be a form of myocardial injury. Cases of myocarditis, these are usually clinically managed, and people are usually discharged from the hospital following treatment. Those who die in a time frame that is temporally related with the vaccine are rare. This temporal relationship is not sufficient to attribute causality, and these particular cases deserve a careful and detailed study to understand these underlying mechanisms. And as I mentioned, these clinical cases, these usually resolve. However, most of them are not usually biopsied. Please remember that the clinical diagnosis of myocarditis is not always based on a biopsy. The clinical diagnosis of myocarditis is usually based on several criteria, and these are usually assigned with relative probabilities of that diagnosis. So these are the different vaccine platforms that were listed in the paper, but we do know that there's an mRNA group of vaccines, we have viral vectors, and there's also a protein subunit, which this Novavax is not actually in circulation. We know the Janssen vaccine is not in circulation either, but just being aware of the different platforms is very important. Now, per the CDC, forgive the busyness of this slide. I've kind of touched on this a little bit, but the CDC does admit there is a causal association. But when cases have occurred, the most frequently seen cases seem to be in adolescent and young adult males within a week after receiving the second dose. However, they have been seen in other age groups, and also in females and in other doses. The severity, though, of the myocarditis and pericarditis can vary, and most patients with myocarditis after the mRNA vaccination, they do resolve their symptoms. And then I mentioned already that the Novavax vaccine is currently not authorized to be used because they did do a study, and in this study there were 6 cases of myocarditis and pericarditis out of 40,000 participants in this particular trial. So let's go over the introduction here. So in this paper, they had a very robust discussion with regard to the spike protein, and they didn't really back it up with data. They did talk about antibody reactions, and they mentioned this concept that the spike protein wasn't neutralized. I don't know how they did that. That there's overproduction of immunoglobulin. Well, overproduction of immunoglobulin is what you want to happen when you get a vaccine. But nonetheless, nothing was really sussed out in the introduction regarding this topic. They mention a study where spike protein and not nucleocapsid was located in the myocardial tissue, and this was associated with CD4 T lymphocytes. And they use this data kind of rogue, saying that this suggests that the vaccine is definitely associated with the inflammation. They bring this up later also in the discussion, and they also have pictures. I'm not familiar with this stain, but it's really hard to interpret. Um, and I will mention I didn't have time to look through all these studies that they cited in the introduction, and I am very interested in the methodology used because I didn't feel like I got a good idea of the methodology used here. I didn't feel like the substantiation was appropriate. The content did appear biased and specifically selected and emphasized with purposeful omission of the supporting data and methodology behind it. So they also talk about VAERS data, and this is our vaccine report system. They emphasize data and elucidate these thousands of cases that are reported, but we all know that reports don't equate to cases. And each case has to be really evaluated sensitively, and it has to be researched and proven. So I felt that this point was pretty misleading. The authors claimed that their aim for the review was to investigate potential causal links between COVID-19 vaccines and death from myocarditis using a postmortem analysis. So that's their narrowed in statement. That's what they're shooting for. They mentioned that the literature was reviewed for cases of autopsy data and it was associated with vaccination, and they were looking for different terms like myocarditis, autopsy, SARS-CoV-2 vaccine, and all of these were through the date July 3rd, 2023. They mention inclusion criteria, they mention exclusion criteria. The inclusion criteria says all autopsy studies. The exclusion criteria included articles with no reported vaccination status, with no autopsy reports, without any myocarditis, which why would there not be autopsy results if you're looking for autopsy studies in the first place? I didn't understand that, but nonetheless, this is what they listed. The entirety of the studies that were reviewed in this paper were by authors NH and PAM. These are the abbreviations, but those authors are listed on the other page. Now, they determined the eligibility for the inclusion, and they removed ineligible or duplicate studies. I felt like no detail was provided on this ineligibility and disagreements. It was very rare or very vague, and the disagreements supposedly had prompted their discussion and consensus, but none of that was detailed. And again, like I said before, none of these authors were cardiopathologists. And furthermore, none of them were listed as pathologists. And if you're looking at autopsy data, wouldn't you want someone who knows how to do an autopsy, was trained to do so? Further on the methods, two of the authors independently extracted individual case data. So that would include age, sex, vaccine type, dose number, the period of last vaccine, and death, and they put it into a Microsoft Excel. If the data extracted from the included studies were not identical between the two authors, I guess they compared their Excel sheets. They had a discussion and they re-extracted, and then they reached a consensus. Again, no details provided about this. No supplemental information with hard data was submitted. And can we be sure that this consensus is free from bias between two non-pathology trained individuals reviewing autopsy data? Furthermore, descriptive statistics were calculated using all available data. What does this mean and how was it calculated? That's my question. In the calculation of mean age, estimated age values were actually excluded. And I personally thought this was a problem because a lot of times we use estimated age values in research studies for, making something anonymous. I worry a large reason many of the cases were excluded could have been this, which further weakens any conclusions you make, the smaller sample size you have. So, having an estimated age value exclusion, that's a little strange to me. My next point, so causality in each case, they said they assessed in accordance with an independent review by these three qualified physicians with experience and expertise in cardiac pathology. And as I said, that is not true. And by the way, how was the causality assessed specifically? Last point, it says a quorum of 2 out of 3 was required. And they required this to establish a highly probable causal link. If this consensus wasn't reached, then there was no link. Well, 2 out of 3 isn't much. To be honest, it sounds pretty inadequate and again, very vague, and it was not elucidated regarding the methods. So the adjudicators used all available data and they assessed any temporal relationships, which, later in the article, you'll see there's a bar graph with the temporal relationships, but you can't ascribe causality just because of the temporal relationship. You got to prove it. And, Dr. Sampson, you'll remember, he who accuses must prove. That is a quote that I pretty much live by every day in my practice. The strength of evidence and the consistency with well described COVID vaccine induced myocarditis characteristics and mechanisms. So, how did they specifically use this? These mechanisms were not discussed, and there was not development in the article about this. And then they mentioned possible alternate causes of death to evaluate the causal link. So they say they're going to do this, but I personally don't feel that alternate causes of death were really developed. I didn't see of it. I didn't see this. I saw some suggestion of other things, and I'll talk about that towards the end. But also, if you don't have autopsy or pathology experience, I don't feel this small group of individuals is equipped to do that. So this is a figure from the article. It kind of shows you their flow of, getting the records and then kind of whittling it down. But if you look at my red arrow, I'm pointing to a whole bunch of records that got excluded because it said there was no autopsy. That's a lot of cases. I don't really understand that point right there. Is why. But it says there's no autopsy. So I'm not really sure. It would have been nice to have an explanation for that. This pie chart, it is the colors of my alma mater, but this is very misleading because this pie chart says, okay, this is the proportion of cases affected by the cases by affected organ system. Well, if you're enriching your cases with myocarditis cases, of course the cardiovascular system is the biggest one, right? I mean, what's the point of this? So here's a comment regarding the tables towards the end. You'll see at the very end of the article, there's several tables that are pretty detailed with kind of the demographics of the cases, some of the findings, histology, background history. They did show some terminology that I know not all of us would agree with, but they have some terminologies, but they did explain that a lot of these cases did have underlying cardiac disease. So severe coronary sclerosis, myofibrosis disarray. There was another case that had encephalitis, vasculitis. Fibrosis was seen in a lot of cases. People had remote MIs. There was an anaphylaxis terminology mentioned. There was also a case with an aortic dissection. And, their conclusions rallied and said, this is definitely, highly likely vaccine related. And I'm not the kind of person that will lump myself into one or the other. I don't think it is one or the other. And many of you know, if you've been working with myocarditis for a long time, there are many shades of gray. So I do think that there wasn't enough emphasis on these other factors that could have made a difference in these persons' diagnoses. And I do think it's important to develop that. And maybe we can highlight individuals with underlying predispositions that maybe shouldn't receive the vaccine. But I think that it can be done the right way. It just wasn't done the right way here. In the discussion, they do mention the term deleterious effects. of this spike protein. I felt this was overly perpetuated throughout the paper. Again, more of an opinion piece. We know that many mechanisms of this disease and many mechanisms occurring with vaccines, not just COVID vaccine or SARS-CoV-2, but even myocarditis, many mechanisms are still an active area of research. And stark conclusions such as these are misleading. Differences for the histologic differences, I said differences twice, but the differences of the differences weren't discussed. So, for instance, one of the papers I'm going to go into talk about more of a toxic cardiomyopathy, which I think many of you probably wouldn't call that a myocarditis, versus a lymphocytic infiltrate or a lymphocytic myocarditis. So there wasn't a discussion on that and a comparison of the histology. And I think that's a very crucial point to be talking about when you're talking about calling something myocarditis, especially in the setting of an autopsy. Um, the limitations of diagnosing myocarditis were not discussed. Photomicrographs from another study, which I've already referenced with the spike proteins, those were presented, and the staining patterns are difficult to appreciate, and the conclusions drawn were questionable. And again, I say I don't have much experience with this particular stain. And furthermore, there were some statements made in that figure that said that the CD4 T cells dominated this inflammatory cardiomyopathy, and another statement
Oh,
mentions. Can you hear me?
yeah.
And another statement mentions inflammatory dilated cardiomyopathy, which that raises a whole bunch of questions. Was this dilated cardiomyopathy there before? Um, can you please elaborate on that? So much of the content was not evidence-based or explained. The limitations that the authors went into, they said that, oh, these limitations are the typical limitations you would see with a small sample size. They mentioned selection biases of cases for autopsy. Well, okay, I'll give Jack his jacket. I can understand this. There may be a state and a county difference on how these cases are dealt with. Medical examiner's office too, and I work in one. And as far as I'm aware, many have different thresholds or criteria to autopsy these cases, or furthermore, to even bring in the cases for an autopsy. So there's a lot of heterogeneity associated with these cases. We usually ask people, have you had a vaccine in the last 2 hours? I mean, I think it's an important topic to discuss, and I think there needs to be more uniformity. So I can understand that there is a selection bias. Um, they mentioned publication bias against disclosing more cases from an academic medical center and medical examiners for fear of reprisal. An elaboration on this would have been helpful because I don't know what they're alluding to. Unknown confounders such as undetected cardiotropic pathogens, which they really didn't develop the pathogen discussion to begin with, but alcohol abuse, drug abuse, and these are all threats to validity. Well, at least one of the papers I looked at did discuss that they did toxicology. I mean, some of these ideas were not even brought up, but confounders may actually be an alternate cause of death or heavily contributory. So it is important. But what about all the other underlying natural cardiac diseases? What about all the extra cardiac diseases? We're talking about atherosclerosis, hypertension, cardiomyopathies, channelopathies. Yeah, I know they mentioned the SCN5A gene, but it wasn't developed enough. Now, this slide, everybody knows cardiopathology expertise is crucial because we're all cardiopathologists, most of us. But a diagnosis of myocarditis, this is mainly for some of the folks out there who may not appreciate this, but it's not always easy, as most of us know. And furthermore, assigning fatality to it solely, that's a whole nother discussion. As many of you have seen, people with gunshot wounds who, if you happen to do histology, because when you're a fellow, you do histology on everything, sometimes they have myocarditis. I would like to eventually go through all the papers mentioned in this article because um, I would like to really read all on my own, and I haven't been keeping up with this topic as I wish I would have. But I do encourage all of our members, if you can, look at the papers. Try to maybe one per week or something. I'm going to try to go through those and see what else is out there. Although it was mentioned that the authors did have cardiac expertise, I already mentioned this probably like 10 times, but that's an important piece to this whole paper. And I don't agree with it. Other concerns, No in-depth discussion on molecular genetic testing performed, despite the honorable mention of our SCN5A gene. I will say that the CDC does have recommendations on how to triage and handle these sorts of autopsy cases, and doing, extra testing is always encouraged. Now, one of those extra tests would be a viral panel because you can look for co-infections. I've seen people with both COVID and influenza. So it would be important to know this interaction of what's occurring in people. We can't just be narrow kind of viewed. It seems like there was some focus on this temporal relationship without analyzing other important pathology. And there was a phrase in particular that was used, and it was excess mortality when discussing the vaccine, that I just felt was simply an untrue statement. So you've heard this before. We need more studies. Obviously, histology is helpful. I don't know how you guys feel about people coming into the hospital and getting a myocardial biopsy. Obviously, we would give us more data. It's a pretty invasive procedure. And if they're not going to show the typical myocarditis, I don't know what the yield would be. We need to better identify the cases, especially in medical examiner's office. We need to understand as a public and as a clinical sector, and I think mostly on the clinical standpoint, myocardial injury versus myocarditis. So myocarditis is just one of the types of myocardial injury. And so these can be occurring in persons that are called to have myocarditis, and keeping an open mind instead of jumping to quick polarizing conclusions. There are more shades of gray than we realize. So, as a last, a little treat at the end of this paper, I'm going to talk about a kind of, it's two different cases of vaccine related deaths in young men, and it's a colleague of mine who I adore. But I'm going to go through this article. I'm going to talk about the CDC's reply to it because there was some omitted data here. Some of you may have already read this. And then just to kind of stimulate discussion. So this article depicts two adolescent or teenage men who had non-typical myocarditis. It was non-typical pathology observed in these two boys. They were found dead in bed 3 and 4 days after they received an mRNA vaccine. They did not have any resuscitative efforts. The histology resembled what we typically see in a stress cardiomyopathy or a toxic cardiomyopathy, and contraction bands, neutrophilic infiltrates, and histiocytes, these were seen in the interstitium. There was mostly a paucity, or there were low levels of lymphocytes. One of the hearts did have subepicardial and transmural fibrosis. This is super important because it did look like it was more developed to fit in the time frame of the first vaccine. So apparently, in this particular case, the first dose of the vaccine was given 3 weeks prior, and the fibrosis appeared to predate this vaccine. The molecular testing in this case did show two VUSs, and then the other case was the heart was 520 grams with some dilatation, and this individual was noted to be obese. And this person also had similar histologic findings, a little more severe. So the CDC responded to this article. It seemed like they were somewhat incomplete because they felt that there were some data points that should have been brought up in the article, which I don't disagree entirely, but you'll see, we'll go into it. So the CDC did respond. They mentioned they did perform testing for SARS-CoV-2, and they didn't have evidence of infection in the autopsy tissues from both of the decedents. They did test formalin-fixed heart tissue, and they also tested formalin-fixed heart tissue for enterovirus and parvovirus. They did do a Gram-Warthin Stari stain, and there was no bacteria that they could see with those. Um, and then case B had adrenal hemorrhage, and they did see a bunch of bacterial foci in other organs, and the testing was positive for Clostridium septicum. They say that the Clostridium septicum is not normal flora, but then there's articles that say it is. But they really heavily thought that this Clostridium septicum was more of the issue here. And many of us autopsy pathologists, we're used to seeing, these bacteria all over the place in a postmortem specimen, even with just a touch of decomposition. So the CDC stated that they offered an alternate cause of death for case A and case B, the former being parvovirus and the latter being clostridial sepsis. And so parvovirus did test positive in the first case, but all of us know the issue with parvovirus, right? So here was the author's reply, and I highlighted a few areas that I thought were pertinent. So this is what they thought, and I don't necessarily disagree. It misinterpreted common postmortem findings, including bacterial overgrowth. This is what causes bodies to putrefy after death as the intestinal flora spread. And also, the inflammatory infiltrates were not associated with these areas of bacteria, is the other point that they mentioned. Clostridium septicum is a small component of the human colon flora, and it rarely does cause infection. It has been described to cause sepsis with colonic malignancies that offer a portal into the circulation. And also, the diagnosis was not included because it was a postmortem artifact. And lastly, they did conclude that the detection of parvovirus genome was an incidental finding because we all know that there are hearts that have it in it, and we can't always ascribe a cause to their cardiomyopathy with it. But I know this is a little bit of a contentious topic. Now, last slide, I believe. There's another paper that I had just started to dabble into, and I just did not have the time to do so. But I saw that some of our lovely cardiopathology society members did respond to this one. Thank goodness. I didn't have time to develop a discussion of this paper, but I want to just put this up here for anyone who would like it to maybe do a little homework. Thank you very much for listening to me, and look forward to the discussion.
Thank you, Sarah. This is very in-depth understanding and analysis of a very controversial paper and some really in-depth discussion about autopsy finding for COVID-19. So let's open the floor and see the comment from our experts.
Well, just one of the comments that I have and that has been brought up by others in the forensic area is that, and it was also mentioned by Sarah, basically, that these authors had some affiliation with a proprietary company called the Wellness Corporation. And I think it's, and I don't want to be too redundant here, but I think I think that's what offers some alternatives to treating COVID virus. And so they're trying to nudge people toward using their product rather than the vaccines. I think that's probably, I wrote down some thoughts that pretty much echo what Sarah has said. So I guess the last question I have, or my last comment, is that the staining in figure 4 looked artifactual. I think that was the staining, I believe, for spike protein. It just looked like it was smearing of the coloring agent, not distinctly identifying particular antigens.
I agree. If I saw a slide with this kind of stain, I would ignore that. I just say it's artifact.
Exactly. I did too. That was the first thing I thought.
Richard, you have some comment?
Well, no, in fact, Steve addressed my original question. I mean, other than fame and fortune, what were these people, what axe did they have to grind? And I think Steve has provided a potential answer to that.
Hi, Sarah. It's Ali Krywanzik here, and thank you for a interesting article choice.
Oh, hey, yeah.
Hey,
Good to see you.
nice to see you too virtually. I don't think I have my camera on because I'm just a mess right here. But one of the things that I think it's not just unique to this article, but I think a lot of the issues when we talk about this, quote unquote, morbidity and mortality of the COVID-19 vaccine. It reminds me a lot of discussions we had in medical school around the side effects of birth control pills, right? And so the side effects of birth control include, thrombus, thromboembolism, DVTs. And so people sort of develop a fear around it. But the fact is that if that's a complication of, oral contraceptives, then it's definitely a complication of pregnancy, right? And so to say, looking at the risks of a COVID-19 vaccination, we shouldn't really be comparing it to the risk of nothing. We should be comparing it to the risk with COVID infection. And we can talk about spike proteins and things like that in the vaccine, but those are also on the virus. So it's kind of unfair to write about the risks of the vaccine in a vacuum and acting like there's not a background other risk factor. There's a reason why people are getting the vaccine.
Right, and we are developing this list of known therapeutic complication from this vaccine. Most, you heard this statement, if the disease doesn't get you, the treatment will. And we're figuring this stuff out, and it becomes very political and difficult to navigate when you have misinformation such as this. And I think that the other point is to gently and properly go through research and look at this. This will be nice because maybe we can identify individuals that we'll say, hey, maybe you shouldn't receive the vaccine because we know that this, and this will put you at a increased risk, but it's going to help everyone else. And at least we can do our due diligence in that regard.
So sorry, it's Paulina Lackey here. Sorry, am I talking out of turn? Can I go ahead?
Yeah, please.
I just wanted to say, so I personally know two of the authors here, and I just wanted to correct something. Roger Hodkinson actually is a pathologist. He just hasn't practiced pathology for many, many years. He is not a cardiac pathologist. He's not a forensic pathologist. He's not an autopsy pathologist. And, but he is a pathologist somewhere in there. He still has a license in Alberta, but he's under investigation right now. And William Makis does not have a license to practice medicine. He actually had his license taken away and his privileges. I mean, I think in here it says, I don't know what he says. He's affiliated with the Cross Cancer Institute and Alberta Health Services. And that is not true. He has not been with Cross Cancer Institute or Alberta Health Services for many years. And he does not have a license. He's not a licensed physician.
I appreciate you sharing that with us.
This is Dr. Postelnik. One question that never seems to be answered is the incidence of myocarditis post-COVID vaccine in comparison to any other vaccines that are administered. So that's always the social media,
of course,
broadcast media take on these things.
If you do a PubMed search, and I mean, I'm not going to draw a conclusion of this, but I'll just mention it. And you type in myocarditis vaccine and you filter for the years, around the COVID time, it's just exploded. But then before that, there's a few reports, but they're very scant. There were a few vaccines that can result in it. And I mean, I guess it seems, I don't know the numbers and I'm sure we could find them. It seems like it is higher. There is a higher incidence with the COVID vaccine, but COVID vaccine is not the only cause of vaccine-related myocarditis. That doesn't fully answer your question, but I really appreciate what you're bringing up.
Mark?
Yeah, I like, agree with everything that people have said here about the paper, the people who are doing it, the agenda, etc. I think the frustrating thing that we're experiencing is that it was published in a respectable journal, and we have to wonder what the editors of that journal were thinking. Had they not done their due diligence on who the authors were, who were the reviewers who let this go through, because Sarah pointed out numerous issues with this. If this might go to the situation where people have request their reviewers. So it could be a reviewer friendly to their belief system that could push it through without editorial oversight. So I think one of the lessons from this, and sort of mentioned before, just because it's in a good journal does not make it a good paper. And we have to really hold our journals and our editors more accountable for situations like this.
Here, here.
Yeah,
Yeah, I have to agree. Oh, sorry, it's Charles speaking. Great talk. I mean, looking through this article, particularly the figure 6, it's frightening. It's like it's dramatic. The last image is of this person collapsed and all blacked out, and you know, on multiple occasions, there's very kind of dramatic imagery of what might happen given the vaccine. It's just it's frightening on face value, but also frightening that it gets published, and we all know with social media what can happen. So I think just a general comment that I think it's a good article to bring up despite all of its shortcomings, because it highlights a bigger issue surrounding, you know, publications in general, but specifically vaccines and COVID-19.
Yes, and I didn't even talk about it, but the picture of the figure with the sudden adult death syndrome,
It's wild.
It's very challenging. Yeah.
So sorry, it's Paulina Lackey again. I just want to tell you about some things that are happening in Alberta. So these unexplained adult deaths and unexplained children deaths, you're going to hear that from Canada a little bit and from Alberta. And actually the government made a big mistake and released numbers of, and they interpreted these numbers as being unexplained deaths. And what they were is they're deaths from the medical examiner's office that just haven't been finalized yet.
Oh dear.
So there was a really big problem with that, and that's sort of
Wow.
I'm
thankful you're here to
I hope that has been
explain
corrected.
this. Yeah.
And I'm just going to if you go to the College of Physicians and Surgeons of Alberta and you look up Dr. Hodkinson, he is under investigation right now. And I'm just going to say some of the things that he's being investigated for. That he made statements like COVID is nothing more than a bad flu season. He's made statements that masks are utterly useless. There is no evidence based on their effectiveness whatsoever. He gave a statement that give them all to 3,000 to 5,000 international units of vitamin D every day, which has been shown to radically reduce the likelihood of infection. And you're being led down the garden path by the chief medical officer of health for the province. And sorry, this is also about he went to city council and he claimed that he was a virologist, and he's not. So I just,
oh dear.
I think it's important to, I mean, I'm not doing character assassination. I'm just telling you what evidence there is and how these people are being investigated. And I think that these, this investigation by the College of Physicians and Surgeons, it's like a medical board, right? Shows that he has pretty strong biases.
Yeah, definitely.
Yeah,
And I'm sorry, but I tried to find the video. There actually was a video with him claiming all these things, and it has been taken down from YouTube.
Sarah, you mentioned the idea to write a letter to try to
I was
the
thinking
paper.
about it. I mean, what do you guys think about it? I mean, I also want to find out if it got withdrawn. So is it worth it?
If it hasn't got withdrawn, I think so, especially the issues with the terms used for what is, you know, what is considered myocarditis and what you're stamping as myocarditis, and how that really cannot be used as, you know, plastically, for lack of another term, or easily as it is in this article and others. But I think it might be worth it if the article's not withdrawn, given the issues that you've brought up and the danger potentially of leaving it as is.
Yeah, definitely. It's scary.
Yeah, I think it's a really good idea, given the so many questions, so many problems in the articles, and it's still in circulation. It's dangerous to the public.
It is. It's very dangerous. It reminds me of an article a few years back in the forensic community. I think Barbara will agree, that we had an article and it just wasn't founded on good data, and it was very, very misleading. And it's very scary that, like Mark said, how did this even get through?
Hey, this
So,
is JU. Actually, someone already wrote a letter to editor
oh,
for
perfect.
this one. I just opened it. I haven't really read it, but I'm going to post on the link
Yes,
in the
please. Yes.
chat. Yeah, so somebody already wrote a letter regarding this article.
Excellent. Excellent.
I think it may be worth considering a letter, perhaps even from the society, if nothing else, to get the editors more engaged in the review process, because clearly this was a failure of editorial oversight.
Yes.
Totally agree. Like, how good is a pathologist reviewer, right? How a good pathologist can allow this happen. Yes, Rick?
Yeah, so going forward too, is it worthwhile, at least in the forensic community where these cases are appearing, to advocate for having a kind of a central adjudication clearinghouse? And maybe something that the society can either name or SCVP could set up, and then actually provide some rigor to the entire analysis?
I think we can suggest that, right?
I think so, and I'm still navigating Florida. I've been here, I guess, just over a year and a half, and I'm still navigating kind of what comes in, how do we ask, and how are they looking at these cases. I know in our state we do keep track. All the vaccines are reportable, and they can actually extract data on deaths, and then they can compare those. I don't know what it's like for all the states, but I think more efforts need to be in place. So I do agree with that.
Alison?
So just in terms of, I've heard, I don't want to be cynical, but sharing the cynical perspective perhaps of, one could consider this a miss from the editor's point of view, or in the era of predominantly digital journals, this is a big win for them, because this, controversial is going to increase their site traffic, which is going to bump up their advertising revenue. So it's no longer, people pay and you get a physical copy of a journal for the entire year. They're getting revenue based on how many people are going to download it or how many people go and click on the link, even if they have to retract it in 3 months. And I think we've seen similar issues with some other articles, and I don't know the editors, so I can't speak to that. But I know that that's been alleged to be some of the motivation behind some other very controversial scientific articles that have been published.
Yeah, I can see that.
Hey, this is Jay. I'm going to steal the last 2 minutes for a quick announcement. So next week, actually almost 2 weeks, in July 9th, we're going to have a new series of educational and fun discussion of SCVP activity. The name for now, thank you, Rick, is Matter of the Heart. So we're going to start a kind of year-round open mic discussions, and then Dylan sent out the link and then the email, but it's just in case anyone like accidentally deleted. It's July 9th, 1 p.m. Eastern Daylight Time, 12 p.m. Central Time, 7 p.m. European Italian Time, and then I hope I can see many of you here as well. Sorry, Peter, I just want to make the announcement in case anyone missed the email that Dylan sent out earlier.
Sure. I like the term matters heart, right? Heart matters. I like it. Yeah. So Sarah, if you want to initiate the letter, so I really want to join you. Let me know.
Excellent. Excellent.
Very
Yeah,
good.
and feel free, if anyone has things that they're just dying to say or want to be in it, just email me with just a little description of what you'd like me to incorporate. and we can work on getting this together.
Very good. Thank you so much. It's a really lovely and good discussion. Thank you.
Thank you. Thank you.